So I'm a gastroenterologist at St Mark's Hospital, and with Fiona, advisor to NHS England, specifically about the new Lynch bowel cancer screening programme for England. Now, there probably are maybe people from other nations in the UK here. I would say that England as a nation is a pioneer as a health system in implementing this kind of programme. Nothing quite exists like this anywhere in the world. And other nations in the UK will be looking to how it works in England and maybe thinking about implementing the same system in their nations. So if you're in Scotland or Wales or elsewhere, then this hopefully is around the corner for you as well. But we had, I skipped on already. So we had this meeting at 2016, which is a multi-society meeting. I think, John, you're almost certainly on there, and Ian and Fiona and a few others. And we thought there were three things needed. So this recommendation had just been developed that all new colorectal cancer should be tested for Lynch syndrome. But that was fine, but ultimately, if you're diagnosing people, you need to offer them optimal, ongoing or lifelong care. You need to know who the population are, and you need people to be effectively diagnosing, so you need leadership locally. These three recommendations have formed the basis for three national projects in England. The project that Adam discussed this morning, Finding the Missing 95%, the Lynch Bowel Cancer Screening Programme, which launched in July, and the National Registry Project, about which you've heard something already. But diagnosis needs to be followed with optimal lifelong care. And this figure sort of summarises some of the key aspects of care that everyone with Lynch syndrome should have as a baseline. And there are other things to consider, but essentially we recommend 2-yearly colonoscopy, aspirin, gynecological risk management. For many people this might mean preventative surgery, but there are other things as well. And then when somebody's diagnosed with cancer, then we can adapt how that cancer is treated. We can adapt our surgical or oncological approach. And we'll hear from Noreen Starling this afternoon about some more about that as well. But obviously, I'm going to focus on colorectal cancer for the remainder of this talk. In the UK, and this is across the whole of the UK, we recommend that people with Lynch syndrome should have a colonoscopy every 2 years, either starting at age 25 for what we consider high-risk genotypes, or age 35 for the high-risk genotypes, but not quite as high, where the risk of cancer starts from a later age. And this gene-specific approach we can extend to how we treat cancer. So for the higher risk genotypes, we might consider a different approach to surgery, which I'm not going to go into in too much detail. But the thing about the genotype, so the underlying gene that you carry is associated with a different lifetime risk of developing cancer, and that risk starts to increase at different ages depending on which gene that you carry. And on that basis, we can adjust how we approach, and ultimately we might move to a very individualized approach to surveillance or lifelong screening, which is where we incorporate lots of factors about personal history, medical history, family history, age, previous history of cancer. But really, that's a very sophisticated model, and it's not easily implemented in a health service. So we have to develop something which is feasible, and otherwise you will have a huge variation in care. But at the moment, we're starting to create a little more of a personal approach to how we follow people up on the basis of gene. In July, as I said, and others have mentioned, in England, we have launched the new Lynch bowel cancer screening service. And it's the first service of its kind anywhere in the world, because it's the first service which has ascertained the entire population of people that we have diagnosed with Lynch syndrome. I'll explain how we went about that in a moment. And ensure that everyone has equal access to high quality colonoscopy at a location that's close to where they live. And if you live in Stamford Bridge in Chelsea in West London, and you move to Stamford Bridge in Yorkshire, you'll automatically be offered a colonoscopy in Yorkshire next time it's coming around. You won't have to do anything apart from have a GP in Yorkshire, but everything else will happen automatically. You'll never have to go to a GP to be asked to be referred for a colonoscopy, and you never have to explain to your GP what Lynch syndrome is. essentially it helps people navigate that pathway, and it makes it easier for everyone, in clinicians and people with Lynch syndrome, to access a high quality colonoscopy every 2 years. In the bowel cancer screening program, I'm a bowel cancer screening colonoscopist, and I really, for me, it's the Rolls Royce of the NHS. Because as a bowel cancer screening colonoscopist, I work as part of a fantastic team. You'll hear from JV in a moment. JV is a screening practitioner, SSP, and SSPs are really central to a good patient experience as they go through the process of having colonoscopy. And many of you will have been through this already and maybe experienced this. But essentially, an SSP will meet someone before the colonoscopy, they will be there during the colonoscopy, and they will share the results a week after the colonoscopy. So none of this kind of waiting for 6 months, I haven't had my result, does that mean it's okay, I'm not really sure, or I get a letter, but it's like, 3 months later. People will get their results a week after the colonoscopy, and they will be automatically booked in. They won't have to ask to be booked or chase up their appointments ever again. The other thing that's important about the bowel cancer screening program, really, which is very important, for me, it's the whole team thing that really makes it work well, and the timeliness and the quality assurance. But as a colonoscopist, lots of people perform colonoscopy, but as a colonoscopist, in order to be able to be a bowel cancer screening colonoscopist, you have to undergo additional accreditations. So you have to have high levels of performance. You have to have the highest levels of, being able to get around the whole colon and being able to maintain comfort in patients undergoing colonoscopy, to find polyps, to find the very, very small ones, to recognize the very subtle changes. And we have to undergo practical and multiple choice written exam. We're observed by other colonoscopists to make sure that we're adequate at colonoscopy. Not adequate, but we are performing at high levels. And so accreditation means that people will be having a colonoscopy with someone who is really quite good at colonoscopy. And that means that people won't have an experience that they come for colonoscopy, they have a terrible time because somebody's causing a lot of discomfort, and they don't know about Lynch syndrome, because all the people on this program now, all the bowel cancer screening program, have undergone training. Everyone from administrators, pathologists, radiologists, endoscopists, nurses, screening practitioners, everyone has received training to make sure that they know what Lynch syndrome is for a start. And you'd be surprised, previously people didn't really know what Lynch syndrome was in many cases. And now I think on the screening program, you can say with certainty that people will know key things. They're not going to be experts necessarily in all aspects, and the program is designed to deliver high quality colonoscopy, but they'll know what Lynch syndrome is, and they'll know what other services need to be accessed and where to go for help. So there's a lot about this program which is of benefit, I think. And who's eligible? So I know most people here, who have Lynch syndrome. Lynch syndrome is defined by having a genetic diagnosis of an abnormality in one of the genes that causes Lynch syndrome that you've heard about, one of 5 different genes. But there are people who have conditions that are maybe not Lynch syndrome. And that's a bit more complicated. So for this program thus far, and like I say, this is the first program of its kind, and so we can learn from this program, maybe think about how we expand it in future years. But essentially, you have to have a genetic diagnosis of Lynch syndrome. You have to be known to a regional genetic service or St. Mark's Hospital, because we're the services that have been diagnosing people since the 1990s. You have to be registered with a GP in England, so you can live in across the River Wye in Wales, but if your GP is on the other side of Chepstow, then you will be eligible. You have to be age eligible according to national guidelines, and have any large bowel. So that could be, 2 centimeters of large bowel, rectal stump, a pouch with the anal transition zone, which is, a very small piece of large bowel, but you're eligible then. And if you're in any doubt, you can contact your genetic service. And I'm going to give you some contact details in case you're wondering why I haven't heard or you're not sure. The thing about Lynch syndrome and colonoscopy, there's nobody else who will have as much colonoscopy in their lifetime as someone with Lynch syndrome. If you have it annually, it'll be 50 colonoscopies over your lifetime. If you have it every 2 years, which is what we recommend, then it's 25 colonoscopies. It's a lot of colonoscopy. And as I said, if somebody has a bad experience, they might not want to come back, and they may not want to have follow-up colonoscopy. And that's, that's a problem, because we know people who don't have regular colonoscopy or present with cancer at a more advanced stage, or there are fewer opportunities to prevent that cancer. We know that women with Lynch syndrome may well have undergone a hysterectomy, either as a preventative procedure or because they've been treated for gynecological cancer. And although we can manage the comfort around colonoscopy more effectively in the programme, an awareness of the specific needs of women who've undergone hysterectomy might mean that they have a better experience, because hysterectomy may be associated with increased discomfort after colonoscopy. Still in the minority of women who've undergone hysterectomy, but still needs to be considered. And there are different approaches, technical ways that we can approach colonoscopy to maximise comfort. CT colonography can be used only as a last resort. Capsule colonoscopy, forget about it. Don't do it. If you've been offered capsule colonoscopy, say no. That's all I will say. If you want to ask me about it later on, that's fine. But it's not appropriate. It's not the right test. What about different ways of approaching colonoscopy, technical ways? Well, we used to use dye spray, and dye spray was a way to try and improve our ability to detect very subtle things in the colon, but it really doesn't work much better in the hands of an expert colonoscopist. So we did a trial in our unit in the bowel cancer screening team, comparing the use of AI and standard examination of the colon, and it doesn't provide any advantage for people who are experts. Although it may help people who are not as good at colonoscopy. So we think the focus should be on a good quality examination with people looking carefully and taking their time to look for subtle things. Slowly withdrawing, spending at least 15 minutes looking at the colon, looking again. Just going to play this video.
See, so the GI Genius also picks up
this is an
what's
AI
clearly a blood
device,
vessel here as well.
Drawn a little green square on what it thinks is a polyp, which is
you have to do your own lesion
cecum.
assessment.
But it's missed this lesion, which we've seen.
That's all right.
Which
is
is
a bit of zoom
kind of
here.
subtle lesion.
Just wondering if this is a little serrated lesion
which
here.
is the beginning of the large bowel, or the top part of the large bowel. And we can,
okay.
just by looking carefully, we can get a better look at this, and we can see, we can change our light source.
I think this is a little, possibly a little serrated lesion here.
So we can zoom in on this
What do you
area.
think?
Yeah, no, I think you're absolutely right.
Although I think I picked that up rather than the GI Genius, so it's obviously a work in progress.
That's the end of that.
You are the GI Genius.
Oh, thank you.
We'll have a role thus far.
But I think this really shows how far we've come with optics.
Should we lift it closer?
AI is a rapidly evolving technology. So
I'm not aware of those studies, actually.
But not yet. So how do we ascertain? We've already seen some of this data. So through the project Adam talked about earlier on, we asked all the diagnostic services to share a list of all the people who've been diagnosed historically with Lynch syndrome, and that information was shared with NDRS, who clean the data up, and then they share that with the screening hubs who send the invitations out. You've seen the slide already. Actually, we're diagnosing now about 2,000 people a year with Lynch syndrome, and that's pretty good, really, I suppose you might think, because of a baseline of about 12,000 people who've been diagnosed historically. 2,000 a year is a big leap. So people get diagnosed. That diagnosis is shared with NHS Digital. Fiona McRonald's there. Fiona cleans up the data, sends it to the screening hubs. The screening hubs around the country then send the invitations out. Then you will be invited to one of 46 bowel cancer screening centres around England, the one that's linked to where your GP is registered, so that's kind of generally closest to where you live. Some of those screening centres have a spoke service, so there are 46 centres, but there are probably about 70 centres that actually provide colonoscopy. It may not be where you've had a colonoscopy previously. In most cases, that's a good thing. Because the centres that you could be offered a colonoscopy previously will never be able to offer the quality assurance, the timeliness, and the regularity that the screening programme will be able to offer you. But some people will have had a very good relationship with the centre that they've been to before, and if provided they're having a good colonoscopy, then carry on. Sometimes then that colonoscopist retires, and then suddenly they haven't got that system to back them up. But people may have very good relationship with someone that they've been attending for a long time. And also, we recognise change is difficult, and therefore, if you're trying to work your way into a new system, well, shouldn't have to take too much because we'll be ascertaining people and inviting them, but actually can be a bit tricky sometimes dealing with change. Some people have opted out because they weren't advised appropriately. So we have a lot of people who come to St. Mark's from all over the country and have been for many years because they essentially wanted to make sure they were having a colonoscopy on time and that somebody was following them up and they were attending otherwise a centre where people didn't really know about Lynch syndrome, for example. Now, we have advised our patients that if they are in Lincolnshire or Plymouth and they're having a colonoscopy at St. Mark's historically, that they should opt into the programme and then they can say, well, I'd like to have my colonoscopy at St. Mark's by the Bowel Cancer Screening Service. No problem. You have that choice. So if you have been attending Manchester, another centre where there's a similar kind of historical service, and you're travelling from somewhere in Yorkshire, you can say, I would like to continue to have my procedure in Manchester, and you have that right as a patient. So you have a choice. You have the option. If you've opted out because you haven't been advised that, please do opt in again, if that's the only reason why you've opted out. If you are not sure if you've been incorporated in the programme, this is the free phone number, it's the screening hub number. You just call up with your NHS number and say, I'm pretty sure I have Lynch syndrome, or I have Lynch syndrome, this is my NHS number, my name, am I on the programme? And they will look up a national database and they will know, oh yes, you are, and you'll be invited for a colonoscopy on the 13th of May in wherever, Shropshire or whatever. That's the number, okay? So please call that number if you're not sure. As I said, the process is quality assured. How am I doing for time? Okay. It will always be performed on time. The screening centres are distributed through England. And if you have a procedure in Shropshire or St. Mark's or Plymouth or Newcastle or wherever, it will be performed to a high standard in the same way. The standardisation, the reporting, the care before, during and after the procedure will be the same. Obviously there are personalities, so there will be some variation, but essentially it will be the same, okay? These are the choices. Have your colonoscopy at your local screening centre, have your colonoscopy at the centre that you were treating. St. Mark's, I'm just saying, because I work there, I'm not saying everyone should come to St. Mark's, but you can have the choice, Oh, gosh, come on down to St. Mark's. Don't tell Sarah Marshall I said that, JB. but actually, if you have a relationship with somewhere and you want to go back, that's fine. You can opt out. And we collect data when people come. Like, are they taking aspirin? Has been a change to the family history? Do they have new gynae symptoms, any skin lesions? And we follow that up through our more holistic service. We know that by doing that, so this is 100 people who come for colonoscopy, 85% will have a change to the clinical management beyond colonoscopy. If we ask them questions about holistic aspects of their care, often it's about aspirin. What else about holistic care? Aspirin, should we stop it before colonoscopy? Does not need to be stopped before colonoscopy. There is a European guideline. Now, it can be stopped. If you're only taking aspirin for Lynch syndrome, it's fine to stop it for a few days before colonoscopy, but it is not essential. And actually, you can remove even large polyps while someone is taking aspirin. But some centres, especially with higher doses of aspirin that people with Lynch syndrome might be taking, may be cautious and may decide that they want to stop aspirin. I think that's fine because there won't be a long delay before the polyp is removed. But you do not need to stop aspirin as routine. Upper GI endoscopy, some people, about 1 in 11 people have had regular upper GI endoscopy. We're learning as people are ascertained into the programme. We don't currently recommend routine upper GI endoscopy for people with Lynch syndrome in the UK because it doesn't work like colonoscopy works. Upper GI endoscopy does not prevent upper GI cancer or detect upper GI cancer at an early stage in the same way that colonoscopy does. We need to have a better tool. We need something better than having it, so you can have a look with a camera in the same way, at the same time. It's actually technically not difficult. People attend one appointment, they can have a camera. But we're offering false reassurance by doing that if we're saying that that is a preventative strategy. So we don't offer routine. We need to do something better. H. pylori eradication is an effective method of preventing cancer in the stomach. We know that if people have a family history of gastric cancer and they have a H. pylori test and they have it treated and eradicated, the long-term risk of upper GI cancer is reduced by around half. And that's based on a large study of people with a family history of gastric cancer, not specifically Lynch syndrome. But we need to do better, and I'll talk about what we need to think about in terms of other screening strategies in a moment. What about shorter intervals? You mentioned that you had an annual colonoscopy. This is a study, and I'm sorry about the data, but it's comparing 3 different countries in Europe, Germany, Netherlands, Finland, where they offered colonoscopy annually, every 2 years, every 3 years. And essentially, there's no risk of cancer is not less if people have more frequent colonoscopy. And the stage of cancer, so we're not finding earlier stage cancers by offering more colonoscopy. You could argue for doing it 3 yearly, potentially. I'm not sure necessarily. I would 100% agree with that. But there is a case. And so it's not really clear that having more colonoscopy is going to help. And people are probably offered, maybe in some cases, excess colonoscopies, partially because they attend somewhere where people don't really know what Lynch syndrome is. You may be the only patient, and they may think, gosh, this was Lynch syndrome. I haven't really had this before, so I'm going to do loads of colonoscopy very frequently, because you may be the only patient attending that centre. There may be reasons why, very good reasons why someone is having an annual colonoscopy if they have inflammatory bowel disease and they have Lynch syndrome, for example, so having 2 different pathologies on a case-by-case basis. There needs to be flexibility. Similarly, upper GI endoscopy, if you have something called Barrett's esophagus, which needs follow-up, then you should have regular follow-up with upper GI endoscopy. So there needs to be some personalisation into how we approach some of these strategies. Just want to talk about screening tests a bit more broadly. So what does it mean to have a screening test? Well, it must be the right test. You know, you can do a test, and you know it's kind of some ways easier just to do a test and not really think about is it going to work or not. You kind of do the test, and you know, and it's kind of like, oh, I've done that, and that's fine. But actually, the test must avoid harm, and tests do come at risks. And sometimes the risks of performing the test far outweigh the benefit. They must be effective at identifying the precursor and therefore be able to prevent the cancer or find the cancer at an earlier stage. In order to understand how that test works, really, optimally, we would know a bit more about what happens before cancer. Some tests like colonoscopy probably happened before we understood what happened before cancer. So we need the test to be the right test. It needs to work. There's no point in performing a test like, this is why we recommend preventative surgery for women at gynecological cancer risk, because we don't know that surveillance is the right thing to do. There's no evidence to suggest that actually it prevents cancer or diagnoses it earlier in the gynecological tract. So we recognise that there are many cancers, and John's going to talk about urological cancer. We need to do better. We cannot say that the tools that we have are good enough for most sites. Okay, we need to have better tools to prevent cancer in the upper GI tract, in the gynecological tract, in the kidneys, and the drainage system of the kidneys. So we need to do better. We need to devise tools, and therefore we need to have research projects. And many of you will have participated in many of these programs. So this is Pebs over here is a research fellow working with Trevor Graham and taking these biopsies like your son has provided. And we're collaborating with David on the Lynch Vax project. And we're trying to understand what are the precursors and what are the molecular changes that occur in normal tissue and in precancerous tissue by taking biopsies at the time of colonoscopy. And thanks to those of you who participated in this study. What about fit testing? Some of you are on the Fit for Lynch program, and this is where people have a fit test every year alongside 2 yearly colonoscopy, because we can maybe use FIT not to replace colonoscopy. It will not replace colonoscopy, but it might be that FIT, which is a tool that measures hemoglobin, which is a breakdown product of blood in the stool, can help to personalize how often somebody should have a colonoscopy. So maybe there are some people who should have it more often, but many people who could have it less often, less bowel prep. And we use FIT in other contexts, the national screening program, people with symptoms and whatnot. We're testing now 2 FIT tests together annually. So we've slightly evolved things. Anyone who's participating in this program, please continue to return the fit kits year on year. And if the fit is abnormal in the intervening year, you will be offered an additional colonoscopy, so we can personalize that follow-up. So people may have a little bit more colonoscopy on the basis of an abnormal fit result. And this is how it might work. This is a patient who's well known to me, who had a faulty MSH2 gene, who during COVID did not want to attend for a colonoscopy, agreed to a fit test, which was raised, and could phone her up and say, look, you've got to have a colonoscopy. And she had this lesion identified in the colon, which we could remove at the time of her endoscopy, and therefore prevent the cancer. So this is how fit might work. What do people think about fit? This is responses from you if you've participated in the Fit for Lynch project or the COVID Fit response program that we developed. So overall, people find that fit kits are easy to use, and they have some level of confidence in fit. My level of confidence will be informed by the outcome of research. We cannot say exactly how useful it will be or what place it will have, but I do believe that it will have a role. We're also learning about who's taking aspirin. So this is some interesting data. Less than 30% of people with Lynch syndrome are taking aspirin, even from those centres where people are enthusiastic about managing Lynch syndrome. We're missing an opportunity for cancer prevention. Most people who are not taking aspirin probably should be taking aspirin. Some are not taking aspirin because they have very, very good reasons, medical reasons, that they tried it, it hasn't worked for them. But mostly people have not taken aspirin because they've not been properly informed and counselled about aspirin. And John will talk about aspirin, so I won't talk about it too much, but we know that aspirin will reduce your long-term risk of colorectal cancer. It works really well alongside colonoscopy. They complement each other, and may reduce the risk of cancers outside the bowel, possibly. John will tell us about this later on. We've got this decision aid to help people understand a bit more about the role of aspirin. So, I'll skip past this because John will talk about this. I've mentioned H. pylori. This is a study demonstrating significant reduction in long-term risk of gastric cancer in people who've had H. pylori test. There are lots of other tests being developed, surveillance strategies, blood tests for something called Raman spectroscopy, blood test for ctDNA, which is circulating free DNA, prostate screening, pancreatic screening, and then urinary DNA analysis we'll hear about. We need to do better. In order to be able to do better, we need to collect data systematically, and we need people to participate in studies that will ultimately feed into a better strategy. And that's it. Thank you very much.
Yeah, I got my letter as part of the bowel screening programme. I had my last colonoscopy in June. But I've been having my colonoscopy with St Thomas's for 20 years now. So I spoke to Adam, because I'm under Adam. Now, I don't obviously want to cancel that because I've got a really good consultant that does it for me. But the data that comes from that colonoscopy, because I believe St Thomas's aren't part of the bowel screening programme, is that correct?
I don't know for sure. I think possibly not. Anyway. Possibly not. So you would be essentially having colonoscopy outside of that new program.
Yeah.
Yeah.
So, and also I'm part of FIT as well. Now, the bowel screening program and FIT, do they combine as far as the data goes?
No. So the Fit for Lynch is a kind of research project that I'm the lead for, and so we collect information, but that's completely separate from the bowel cancer screening project.
Okay.
Yeah.
So I got my letter for the bowel screening program, which linked me to a hospital near where I live, which actually it's easier for me to get to St Thomas's than it is to a more closer one. So I went along for my meeting and I said, well, I didn't really want this. I wanted to stay with St Thomas's. But then they give you, I haven't signed it yet, give you some paperwork that you have to sign out of the bowel screening program.
Yeah.
So what worries me is, obviously I still want to go to St Thomas's because I'm happy there and I've got a good consultant. But the worrying thing, there's not a link between the two.
You can continue to go to St Thomas's. You can also opt back in future years if you opt out now. So
Okay.
you're not signing off for life. You shouldn't be asked to opt out of screening for life. But you can choose not to enter the new program. You've got a good service. St Thomas's is a great endoscopy unit. I know I have friends who work there,
Yeah,
you
I've
know,
got a really
and
good consultant. Yeah, yeah.
yeah. Please say hello to Joel Maudsley for me. He's a good
That's him,
former
yeah.
colleague, and but they, you know, and he's a brilliant colonoscopist. So you know,
Yeah.
great. You've got a good service there, but in the screening program, we wouldn't have to chase you up for your appointments, and you know, it would be more quality assured. But actually, you probably got a very good service, and you don't necessarily need to change.
I mean, that's the only one thing is they're terrible as far as chasing up. I have to chase it up every 2 years. I do 6 months before my actual colonoscopy. I even go up there and not bang on the table, but you know, I go into the office and say, come on, you know, my colonoscopy's due, and you know, I get it done anyway. So, but you do have to be a bit, you know, I know your scheme, you don't need to do that.
Yeah.
But yeah.
Yeah, it sounds like you've missed that a little bit. Tracy, do you mind passing it back?
Can you explain the difference between bowel screening centres and non-bowel screening centres for the people in the room?
Okay.
Because obviously this gentleman's talking about opting in and opting out.
Yeah.
Can you explain why that is?
So there are, you know, hundreds of endoscopy units in the country. Some are, you know, most of the ones that you probably have been attending are NHS endoscopy units, and they have to undergo different levels of accreditation. And there are also some that are patients who have been outsourced to providers that provide services for the NHS. And generally speaking, the quality in those centres is not as good as it is in NHS centres. But within the NHS centres, there are 46 screening centres across England that they're designed to be accessible to population, so people don't have to travel too far, for example. And they are providing colonoscopy to to highest standard, and they're scrutinised to a greater degree than other services. But they're all endoscopy providers. They all provide colonoscopy. Does that answer the question, Tracy?
Yeah, so I think a lot of people get confused with the fact that why do I have to opt out of a programme if my centre is a non-bowel screening centre? Is it because they don't have access to the data that the bowel screening centres have, correct?
And the bowel cancer screening service cannot quality assure the colonoscopy that goes on in those centres. Although it may well be very good, actually we know that has been incredibly variable historically.
Doing a workout. Here we go. I've got my sports bra on.
I just wanted to ask about the cessation of screening after the age of 65, which I believe is the current practice in most cases. It's my layman's understanding that actually the risk of bowel cancer continues to increase with age. So it seems to me that there's a disconnect there. I do understand the argument that the bowel becomes more fragile, etc. But what's your evaluation of the risk versus gain there? And is there a way to continue, or is it simply to go privately at this point?
It's a good question. So it's 75, and at 75, people, what we typically would do after people reach 75, before the screening program began, is that we would assess someone's suitability to undergo colonoscopy on an ongoing basis, and that would evaluate whether they have other health issues that might mean that having colonoscopy is, carries additional risk, for example. So if they have heart disease, the bowel prep might be risky, for example. And so they would undergo pre-assessment. So it's more that rather than having routine callback after 75, people would be reevaluated on a more active basis. Now, with the screening program, currently at 75, that ceases, and people would have to have their colonoscopies outside of the screening program, one of these endoscopy units like Joel Maudsley at St Thomas's. But actually, the screening program, we're building the IT at the moment to enable people to opt in after 75. It's just a matter of a few weeks, I think, before that will be available. So people can continue to opt in. And actually, what's happening is that people are being pre-assessed by the screening practitioner prior to the colonoscopy, whatever age they are. So they will undergo a suitability assessment, which means that, is it safe for them to undergo colonoscopy, and is it in their best interest? So you will no way be excluded after 75.